Hi, hello everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos on pathology. Today, in this video, we will discuss iron deficiency anemia. In the iron deficiency anemia, we will discuss what is normal iron metabolism, regulation, and factors of absorption of iron, etiology of iron deficiency anemia, stages of anemia, clinical features, laboratory diagnosis, differential diagnosis, and treatment of iron deficiency anemia and response to therapy. Iron metabolism. Average daily intake of iron in a normal adult is 10 to 20 milligrams, 10% of which is usually absorbed by the body, that is 1 to 2 milligrams. And the chief dietary sources of iron are meat, liver, kidney, egg yolk, green leafy vegetables, and fruits. Milk is a poor source of iron. The dietary iron is in two forms. One is heme iron and other non-heme iron. Heme iron is available in all the animal products and non-heme iron is available in vegetables. Compared to heme iron is more readily absorbed. So animal products intake will give you more iron, that is heme iron, than the eating the vegetables, which consists of non-heme iron. So heme iron is more readily absorbed. Fate of a hemoglobin iron. When the red blood cells complete their life, that is, already you know that RBC life span is 120 days. When it is completed, they become aged or senescent. RBC will be phagocytized by the reticuloendothelial system, liver and spleen, and there will be breakdown of the hemoglobin into heme and globin, and iron is released from the heme into the circulation. Binding of this released iron is taken up by transferrin, which is a beta globulin. Utilization of this iron by marrow erythroblasts for hemoglobin synthesis will happen. Total body iron is 3 to 5 grams, which is proportionate to the body weight. 80% of functional iron is in hemoglobin, that is around 2 to 3 grams. The released iron is converted to storage or available iron, ferritin and hemosiderin 1 gram, non-available or essential iron, myoglobin and other enzymes of cellular respiration 0.5 grams. A small proportion of storage iron is released into the plasma and the iron is transported in the plasma bound to a glycoprotein called as transferrin plasma or transport iron, which is around 0.003 to 0.004 grams, and a small proportion is lost in urine, sweat, sweat, feces, or blood. This was described in the previous slide also in a illustrated form. Coming to the iron absorption, the site of choice for iron absorption is proximal intestines. I for iron, I for intestine, because it has the ideal pH and the key proteins responsible for iron absorption are maximally expressed in this part. So iron is released from the food as ferric or ferrous forms, and the acids will increase absorption. Ascorbic acid, hydrochloric acid, etc. will increase the absorption, whereas the alkaline medium will reduce the absorption. Tannins, phytates, phosphorus, like this. So ferrous form is absorbed in duodenum and upper jejunum. So when we eat, the iron will be in the Fe+3 form. It has to be transported to the duodenum in the form of Fe+2, and to absorb in the body, it is again converted to in the form of Fe+3. As ferric ions polymerize and become less soluble with increase in the duodenal pH, ferrous form is absorbed in duodenum and upper jejunum. Duodenal cytochrome B reductase, a ferric reductase enzyme, is expressed on the enterocytes of the body along the brush borders. They will reduce the ferric to ferrous form to make it a substrate for transport by a transporter DMT, divalent metal transporter DMT1. So from the food, Fe+3 to be absorbed. So first it has to travel throughout the body up to intestines. So it is transported in the form of Fe+2. So it is converted into Fe+3 to Fe+2. And this Fe+2 is carried by a divalent metal transporter 1, DMT1. This DMT1 is not only carrying the Fe+2, it can even carry the copper+2, magnesium+2 ions. So divalent, any metal containing 2 plus will be carried by this transporter. So this is not a specific transporter, but in iron deficiency anemia, as we are discussing, the ferrous form is transported with the help of, if the question is given like this, then the answer is DMT1, divalent metal transporter 1. Mucosal uptake of the heme and non-heme iron occurs through two pathways. First, we will discuss the non-heme iron, and then we will discuss the heme iron. Non-heme iron will enter the apical and basolateral portions of the villus enterocytes by action of transporter protein DMT1. Inside the cell, most of the iron is stored as mucosal ferritin. Remember, storage form of iron is ferritin, tin, container. So, iron is stored in a container. Remember like that. Ferritin storage form. Transporter is transferrin. Transporter of iron is transferrin. Storage form iron is ferritin. So inside the cell, most of the iron is stored as mucosal ferritin and it is not absorbed. These ferritin containing cells are later exfoliated from the mucosal surface into the intestine at the end of their 3 to 4 days lifespan. The remaining iron is transported to plasma with the help of ferroportin. So porting will be done by ferroportin, which is a IREG1 transporter, and it is also done by hapacetin, an iron oxidase. So iron is transported to plasma by ferroportin and hapacetin. So three transporters are there: DMT1, transferrin, ferroportin, ephastin. Among these, ferrous form is transported by DMT1 and the iron is transported to plasma by ferroportin and ephastin. Coming to the heme iron, mechanism is not well understood, but it is thought that when the heme enters the mucosal surface unchanged to release iron within the cells by an action of the enzyme called as hemoxygenase. Iron from this source follows the same pathway as non-heme iron, except that a small portion of the heme iron passes into the plasma intact to bind to hemopexin, a heme binding protein. So, almost the pathway will be similar to that of non-heme iron, but some part of the iron is converted to plasma so that it can combine to a heme binding protein called as hemopexin, and the enzyme involved in release of the iron within the cells is hemoxygenase. So this is a beautiful picture from our Robbins, which is telling how iron absorption is regulated. So the duodenal epithelial cells will take both the heme and non-heme iron. Then the storage of the body are repleted with iron and erythropoietic activity is normal. There will be increased levels of plasma hepcidin. So when there is depleted iron and erythropoietic activity is disturbed, these plasma hepcidin levels are low. That is indirectly proportional. Hepcidin and iron storage sites. This leads to downregulation of the ferroportin and trapping of most of the absorbed iron, which is lost when duodenal epithelial cells are shed into the gut. Conversely, when body iron stores decreases or when erythropoiesis is stimulated, hepcidin levels fall and ferroportin activity increases, allowing a greater fraction of the absorbed iron to be transferred to plasma transferrin DMT1 is divalent metal transporter 1 shown in the picture. So hepcidin is action is indirectly proportional to ferroportin. So when there is ferroportin activity increased, hepcidin levels will fall, and when there is ferroportin activity decreased, hepcidin levels will rise. This is a iron absorption regulatory mechanism. So I am explaining you again this topic as it is very important. Many MCQs will come from this topic. A food iron which is in the form of heme iron or non-heme iron. The heme iron is will be entering into the epithelial cell with the help of heme transporter, and it is stored in the form of mucosal ferritin. And when these cells are shredded off or exfoliated, it will be lost and it will be released into the plasma. This is the journey of heme iron. In between that heme iron, with the help of ferroportin 1 will enter into the blood in the form of Fe plus 2, and again it is converted back to Fe plus 3 and released into the blood, and the plasma transferrin will help in this process, and it is this Fe plus 3 is stored in liver, and few Fe plus 3 is sent to marrow for the formation of hemoglobin. So Ferroportin 1 will help in this process. So when the ferroportin 1 levels are more, to auto-regulate this process, hepcidin levels will be low. And when the hepcidin levels are more, the transport by ferroportin 1 will be reduced. Now coming to non-heme iron, from the food, it is in the form of Fe plus 3. So with the help of duodenal cytochrome B, it is converted to Fe plus 2, and this Fe plus 2 will enter into the epithelial cell with the help of a divalent metal transporter 1, DMT1, which will transport the Fe plus 2, and it is converted to storage form ferritin in the mucosa. In this way, the iron absorption is regulated. So, what are the what are all involved in iron absorption? Option 1, DMT1. Option 2, ferroportin 1. Option C, hepcidin. Option D, all the above. You should mark answer all the above. Hepcidin works against, if the question is given like that, option A, ferroportin 1. Option B, ferroportin 2. Option C, hepcidin. Option D, divalent metal transporter 1. Then the answer will be ferroportin 1. So this I have kept in illustrated form. Fe plus 3 in the diet is solubilized in the acidic stomach. So all the acidic mediums will help in iron absorption. Increased iron absorption will be there in acidic medium, whereas decreased iron absorption will be there in alkaline medium. This is a important point. So this Fe plus 3 has to be converted to Fe plus 2 with the help of a enzyme called as ferric reductase. Okay. Then this Fe plus 2 from the non-heme iron is transported into the epithelial cell with the help of DMT1, that is divalent metal transporter 1. This Fe plus 2 is stored in the mucosa of the epithelial cells in the form of ferritin. So storage form of iron is ferritin. The Fe plus 2 is formed from the heme iron with the help of, and it is transported into the cell with the help of heme carrier protein 1, and it is converted to Fe plus 2 from Fe plus 3 with the help of heme oxygenase. So ferric reductase will help in formation of Fe plus 2 from non-heme iron, and heme oxygenase will help in formation of Fe plus 2 from heme iron. When this Fe plus 2 is formed in the epithelial cell, it has to be transported to blood. So the ferroportin 1 will help the transport of Fe plus 2 from epithelial cell to plasma or blood. Here, hepcidin will help this process, and ferroportin 1 will help this process. The ferroportin 1 process, if it is increased, more and more iron is absorbed into the cell and it is sent to the plasma. So, and the excessive iron is stored in the form of ferritin. So, when there is a stage where excessive iron stores are stored, the hepcidin is released and it will show its function against ferroportin 1. and thereby the process ceases at this point. When there is body is depleted of iron stores, then the hepcidin levels will reduce, which will cause the ferroportin 1 to be active, and more Fe plus 2 ions are transported into the plasma. So again, from Fe plus 2 to be transported to various parts of the blood or various organs through blood in the form of Fe plus 3. And this Fe plus 3 is transported to liver, macrophages, and erythroblasts in the bone marrow in the form of transferrin. So transporter is transferrin and storage form is ferritin. So this question can be asked for 3 marks question: factors increasing and decreasing absorption. Ferrous form acids in the stomach, ascorbic acid, amino acids and sugars in the food, and iron deficiency and physiological conditions like pregnancy and hypoxia will act as factors increasing the absorption of iron. Ferric form Fe plus 3, achlorhydria, that is absence of HCl secretion. All the alkaline foods are the pancreatic secretions, phytates, tannates, and phosphates in the diet. And when there is iron overload or when there is use of tetracyclines and ethylene diamine tetraestic acid EDTA or any inflammatory disorders, these factors will decrease the absorption of iron. So once the absorbed, it has to be stored and transported. Iron is stored in bone marrow, liver, spleen, and skeletal muscle as ferritin and hemosiderin. Ferritin has a spherical outer shell of protein called as apoferritin and an inner core of trivalent iron. So ferritin is Fe plus 3 plus apoferritin. Hemosiderin is more stable, therefore less readily mobilized to hemoglobin formation. So whenever there is a need, first ferritin will be converted for the formation of hemoglobin. Percentage of total iron binding protein to which iron is attached is called as percentage saturation or transferrin saturation. So it can carry maximum 6 Fe plus 3, but at a time it will carry, definitely it will carry 2. So the transferrin percentage saturation or transferrin saturation will be 2 by 6. It is one third. That is 33%. Percentage of age saturation, transferrin saturation is equal to serum iron by total iron binding capacity. Remember these 2 points. This can be asked in MCQs. That's why I'm repeating again and again. Remember, transporter is transferrin. So the iron is transported in blood with the transferrin, and iron is stored in the form of ferritin or hemosiderin. So ferritin in storage form. Out of the ferritin and hemosiderin is more stable form. Ferritin consists of Fe plus 3 ions in the center surrounded by apoferritin. These points are to be remembered lifelong for treating the iron deficiency anemia and to clear the MCQs also. These 2 points are very, very important. Coming to the iron studies, which will help in diagnosis of iron deficiency anemia. That is serum iron levels, normal total iron binding capacity levels to be known. The serum iron levels in a normal adult are 0.7 to 1.8 milligrams per liter. Normal TIBC is 2.5 to 4 milligrams per liter. The normal ferritin levels are 20 to 300 micrograms per liter in males, slightly less, that is 15 to 150 micrograms per less in per liters in females. 20 to 300 micrograms in males and 15 to 150 micrograms per liters in females. Ferritin levels are raised in conditions of acute leukemias, inflammations, and Hodgkin disease, whereas these ferritin levels are decreased in liver disease. So remember the mnemonic HILL. What are all the conditions where ferritin levels are showing variation? One is Hodgkin's disease, inflammation, leukemias, and liver disease. Hodgkin disease, inflammation, and leukemias, there will be raised ferritin levels, and ferritin levels are decreased in liver disease. Iron excretion. Normal average excretion of iron in urine, feces, and sweat per day is about 0.5 to 1 milligrams, and another 0.5 to 1 milligram will be lost in menses in females. Now coming to the etiology, investigations, and differential diagnosis of microcytic hypochromic anemia. Iron deficiency anemia is the most common type of anemia that is met in the clinical practice. The causes are: one is increased blood loss, the other is increased requirement, the other is inadequate dietary intake, and the other is decreased absorption. Total 4: increased blood loss, increased requirement, inadequate dietary intake, and decreased absorption. Dietary lack in infants, children, and low socioeconomic status and elderly people is seen. There will be impaired absorption in tropical sprue, chronic diarrhea, and gastrectomy patients, and few cases of steatorrhea complaint. Increased requirement is the cause for iron deficiency anemia in growing infants and children, pregnant females, and premenopausal women. Chronic blood loss is causing iron deficiency because of GIT problem like peptic ulcer, gastric cancers, hemorrhoids, hookworm disease, or renal, pelvic, or bladder cancers, or sometimes in females, uterine cancers and menorrhagia will cause chronic blood loss, thereby causing decrease in the iron, thereby resulting in iron deficiency anemia. The iron deficiency can be explained in 3 stages. So, immediately the iron deficiency will not be observed. It will take time. So, first stage is storage iron depletion. Second stage is iron deficient erythropoiesis. And the third stage is frank iron deficiency anemia. Decreased iron stores will cause decreased serum iron, TIBC, and transparent saturation or percentage saturation. There will be, so in this stage, normocytic normochromic anemia, which is followed by microcytic hypochromic anemia. So the three stages can be described in this tabular form. There will be variation in all these parameters. So depletion of storage iron, first stage. Iron deficient erythropoiesis, there will be second stage. And finally, it will end up in iron deficiency anemia. When bone marrow iron stores are absent, then it is in first stage. These iron stores, if go on depleted and there is no iron available, then it will go into second stage, iron deficient erythropoiesis. If it is further continued, it will go into iron deficiency anemia. The serum ferritin levels will be low in all these three stages. Total iron binding capacity will be normal in the first stage. In the second stage, it may be normal or increased. In the final stage, that is iron deficient anemia, the total iron binding capacity is increased as there is very much deficiency of iron. The FeP levels will be normal in first stage and increased in second and third stages. Transferrin saturation will be normal in the first stage and it is decreased in second and third stages. Hemoglobin is normal in first stage, whereas it is decreased in second and third stage. With this, MCV will be normal, mean corpuscular volume will be normal to second stage, but in the third stage, it will get reduced. Hypochromasia is not seen in the first stage and second stage, it is seen in the third stage. So, the body, when there is depletion of the storage iron, the red blood cells will be go on by bone marrow will be producing the red blood cells with the available iron, whatever the iron is available, it is go on producing the cells. So most of the values will be normal in this stage. But if this stage is go on continuing, then there will be a problem in the erythropoiesis. So all the precursors will be converted to erythrocytes. This process will be happening, but as there is iron deficiency, so there will be abnormal erythropoiesis. Thereby, this will cause the changes in the parameters. And if this is go on continuing, then there will be a stage where there will be production of hemoglobin, which is deficit of iron. So MCV values will be reduced, hemoglobin will be reduced, transferrin saturation will be reduced. As these are reduced, there will be storage iron available form, that is serum ferritin will be very low, and as all bone marrow iron stores are being depleted, the FeP levels and total iron binding capacity will increase and all the red blood cells will show hypochromasia. Signs and symptoms are due to anemia, epithelial tissue changes, pica, and recurrent infections. We will discuss one by one. First, in iron deficiency anemia, there will be signs and symptoms, and these signs and symptoms will be due to anemia or epithelial tissue changes, pica, recurrent infections. Mnemonic is here. Symptoms of anemia: lassitude, weakness, fatigue, dyspnea, palpitations, angina, cardiac failure, and pallor. Pallor is the manifestation or characteristic feature of anemia. So, this is a picture showing how to assess whether the person is having anemia or not, pallor is there or not. You can observe the conjunctiva, tongue, fingers, and prominent creases are there or not. And you can observe the tongue also, which is pale or showing pallor in anemias. Iron deficiency anemia, there will be spoon-shaped nails called as chylonychia. This is a classical feature for iron deficiency anemia. So there will be spooning normally. Is it true or false? There will not be any spooning. This angular formation when we keep two fingers will be lost. That is clubbing will be lost. That is more clubbing will happen, resulting in spoon-shaped nails, which is called as chylonychia. And see the two tongues pictures. In first picture, it is normal, and the second picture shows anemia. So second change is because of epithelial tissue changes in the nails. Thin, lusterless, brittle show ridging and flattening. This condition is called as spoon-shaped nails or chylonychia. There will be atrophy of papillae, shiny or glazed tongue, glossitis, and angular stomatitis, representing the epithelial tissue changes. And there is a syndrome called as Plummer-Vinson syndrome or Patterson-Kelly syndrome, which can be asked for 3 marks question and an MCQs. A Plummer-Vinson syndrome is characterized by triad. One is chronic iron deficiency, second is dysphagia, and the third is glossitis. It is seen in middle-aged to elderly women who have chronic iron deficiency, and a fine web or band composed of desquamated epithelial cells is present at the esophageal entrance. This is called as post-cricoid web. And these patients present with dysphagia to specific to solids. So Plummer-Vinson syndrome is a triad of chronic iron deficiency, dysphagia, and glossitis. So this picture is showing Plummer-Vinson syndrome consisting of chronic iron deficiency anemia, post-cricoid web or esophageal webs, and dysphagia to solids. Coming to the third clinical feature after the signs, anemia symptoms and signs, coming are epithelial changes. The third one is pica. Pica is eating the non-edible things or craving for the non-edible things simply, or it can be defined as craving to eat substances like dirt, clay, salt, hay, and is a typical manifestation of iron deficiency. So the mother will bring to the OP that the son or daughter is not having food, but when they closely observed them, they are eating in a secret place all the dirt, clay, hairy material, etc. This is a classical feature of iron deficiency anemia called as pica, eating the non-edible things are craving to eat the non-edible things. Dirt, clay, salt, hair, etc. The fourth clinical feature will be there will be recurrent infections. Iron deficiency will induce defective lymphocyte mediated immunity and impairs bacterial killing by phagocytosis, leading to the impaired immunity and thereby recurrent infections. So, iron deficiency will show its impact in lymphocyte mediated immunity, thereby derailing the phagocytosis and thereby causing recurrent infections. So, recurrent infections are very much common in iron deficiency anemia patients. With the completion of clinical features, we will come to laboratory diagnosis. Remember B, B, B. B for blood, B for bone marrow, B for biochemistry. To diagnose iron deficiency anemia, we have to check the blood, we have to check the bone marrow, and we have to check the biochemistry values. In the blood, we will check for hemoglobin, RBC count, retic count, all the red blood cell indices MCV, MCH, MCHC. We will check for the WBCs, we will check for the platelets. In the bone marrow, we will check the cellularity, myeloid to erythroid ratio, how the erythropoiesis is, and what are the marrow iron stores. Or marrow iron is how it is in bone marrow. And coming to the biochemistry, we will check for the serum iron, serum ferritin, total iron binding capacity, and transfer in saturation. Remember FITT, F for ferritin, I for iron, T for transference saturation, and T for TIBC. These biochemistry values will help you in arriving at the diagnosis. When we do the hemoglobin percentage will be decreased, RBC count is decreased, all the red blood cell indices will be low or very much reduced, but red cell distribution width will increase in iron deficiency anemia. In peripheral smear, you can appreciate microcytic hypochromic red blood cells. There will be anisocytosis, and this anisocytosis is indicated by increased red cell distribution width, which is more marked in iron deficiency anemia when compared to thalassemia for same hemoglobin values. So if a thalassemic patient and iron deficiency anemia patient comes with a hemoglobin value of 7, if you observe the peripheral smear, there will be more anisocytosis in iron deficiency anemia when compared to thalassemia. So this RDW will help you in coming to the conclusion or diagnosis of IDA, and it helps in differentiating it from thalassemia. There will be poikilocytosis, and it is less marked in iron deficiency anemia than in thalassemia for the same hemoglobin values. So RDW is more marked in IDA, but poikilocytosis is less marked in IDA. Normoblasts, elliptocytes, pencil-shaped forms, and target cells are common in severe anemia. There will be normal, increased or decreased platelet counts and unremarkable WBCs. Reticulocyte count will be normal or decreased. In post-hemorrhagic anemia, reticulocyte count may be mildly raised. So this is a beautiful peripheral blood smear picture showing microcytic hypochromic red blood cells. There is poikilocytosis and few target cells are seen. Target cell is also called as codocyte. This is one more picture showing the peripheral blood smear, a lymphocyte, microcytes, hypochromic red blood cells, and bone marrow showing myeloid cells and micronormoblastic blood picture. And iron marrow is stained showing the iron depletion or decreased iron levels. In the bone marrow, the blood picture will be, the bone marrow picture will be micronormoblastic erythroid hyperplasia. There will be increased mainly in the mature cells. Presence of erythroid hyperplasia is there. There will be a predominant cell of polychromatic normoblasts, which will be smaller than the normal. So, as there is deficit of iron, the erythropoiesis will go on continuing, but these polychromatic normoblasts are comparatively smaller than the normal normoblasts in a normal erythropoiesis case. So these are called as micronormoblasts. So there will be predominantly micronormoblastic erythroid hyperplasia in iron deficiency anemia. The cytoplasm will show ragged borders. Cytoplasmic maturation will lag behind that of the nucleus because of delayed hemoglobinization. So in microcytic hypochromic anemias, there will be cytoplasmic defect. Remember this point. This can be asked. Cytoplasmic defect is seen in microcytic anemia, macrocytic anemia, hemolytic anemias, all the above. The answer is microcytic hypochromic anemia. If they have given DNA synthesis is derailed or defective in option A, microcytic hypochromic anemia, macrocytic anemia, hemolytic anemia, all the above, then the answer is macrocytic anemia. Microcytic anemia is related to cytoplasmic maturation. Prussian blue stain, which is a special stain for iron, will show decreased iron stores. Coming to the iron studies, are biochemical values. There will be decreased serum iron levels. Transferrin saturation is decreased. Serum ferritin is decreased. And TIBC is increased. Among the FITT, F that is ferritin, I iron, T transferrin are decreased in iron deficiency anemia. Only TIBC is increased. Remember this point. This is very much important in identifying a iron deficiency anemia case. The serum transferrin receptor fragments assay will be helpful, and it is done by immunological methods which will demonstrate an increased values in iron deficiency anemia. So STFR levels will be increased in iron deficiency anemia. Erythrocyte ferritin is decreased in iron deficiency. The FEP levels, that is free erythrocyte zinc protoporphyrin levels, are increased in disorders of heme synthesis, including the iron deficiency. Normally, protoporphyrin binds iron to form heme in erythroid precursors. In iron deficiency anemia, this protoporphyrin will fail to bind with iron, and so its levels are increased. Whereas in thalassemia, FEP levels are normal. So FEP levels are normal in thalassemia, but these levels are increased in iron deficiency anemia. Differential diagnosis, as the peripheral blood smear picture is microcytic hypochromic anemia, the DD will be Sita or Seetal. Remember Sita. mnemonic. S for sideroblastic anemia, A for anemia of chronic disease, T for thalassemias, I for iron deficiency anemia. Sita. Okay. So we have to differentiate these three. Heterozygous form of beta thalassemia trait, RBC count normal to increased, RDW will be normal, target cells will be abundant, there will be basophilic stippling and nucleated RBCs are seen. The iron studies will be normal and there will be increased HbF in thalassemias. Coming to the anemia of chronic disease, the serum iron is decreased. Serum ferritin levels may be normal or increased, whereas it is decreased in iron deficiency anemia. TIBC normal or decreased, which is increased in iron deficiency anemia. Percentage saturation or transferrin saturation is decreased to normal, whereas it is decreased in iron deficiency anemia. Sideroblastic anemia, serum iron is normal or increased, which is reduced in iron deficiency anemia. Serum ferritin is normal or increased, which is decreased in iron deficiency anemia. TIBC is normal, which is increased in iron deficiency anemia. Percentage saturation is normal or increased, which is decreased in iron deficiency anemia. So remember the iron deficiency anemia, FITT, that is serum ferritin, F, serum iron, serum transferrin saturation. All will be reduced in iron deficiency anemia. Only TIBC will be increased in iron deficiency anemia. Increased hemoglobin F, target cells more abundant, basophilic stippling and nucleated RBCs are commonly seen in thalassemias. So this is helping in you to differentiate iron deficiency anemia from thalassemia, sideroblastic anemia, and anemia of chronic disease. So DD for microcytic hypochromic anemia can be asked for a 6 marks question. Then you have to draw a tabular form and write these findings. Coming to the treatment part, the iron deficiency anemia can be treated with the help of oral therapy or parenteral therapy. Oral therapy can be done with the help of intake of ferrous sulfate or ferrous fumarate or ferrous gluconate, and parenteral therapy can be done in the form of injections. Response to therapy: increase in reticulocytes is the earliest hematological evidence of improvement of iron deficiency anemia patients. So in the MCQs they may ask you iron deficiency anemia response to therapy can be seen with the help of RDW, RBC count, reticulocyte count, and none of the above. Answer is reticulocyte count. There will be increase in the reticulocytes as a response to therapy. So this is a mind mapping of iron deficiency anemia. You have to make your own charts so that you can easily learn the things throughout the year and before the exams. These mind mapping techniques will help you a lot to avoid overlapping of the answers and for reading easily in a short time. Remember, iron deficiency anemia is seen in pregnancy, malabsorptions, iron loss, and the blood picture will be microcytic hypochromic red blood cells, Bone marrow will be micronormoblastic erythroid hyperplasia, depleted iron stores on Pelste. Biochemical values will be low ferritin, low transferrin saturation, low serum iron with high total iron binding capacity. Anisocytosis is more marked in iron deficiency anemia than thalassemias. Poikilocytosis is less marked in iron deficiency anemias than thalassemias. Thank you for patient listening. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos on pathology.